Right, thank you, everybody. It's a pleasure to be speaking with you tonight about this amazing study. As we all know, hypofractionated radiation therapy is increasingly utilized for the treatment of prostate cancer. Patients find it more convenient. Treatment is completed in 4 to 6 weeks rather than 8 to 9 weeks. It's also equally effective, with multiple studies showing non-inferior biochemical control outcomes. And it's also a pretty well-tolerated treatment regimen. However, hypofractionated radiation therapy has been associated with increased acute grade 2+ GI toxicity. And this was nicely shown in a meta-analysis that was done in 2017 of several randomized trials, showing that the risk of acute grade 2 or higher GI toxicity, the absolute risk was 9.1% greater for hypofractionated compared with conventionally fractionated radiation therapy. So here we discuss the Barrigel Pivotal Trial, which is the first randomized FDA-reviewed trial evaluating the use of a rectal spacer for hypofractionated radiation therapy. So in terms of this trial, the key inclusion criteria were adults with T1 or T2 clinical stage prostate cancer that was Gleason 7 or lower and had a PSA of 20 or lower. Patients with lymph node disease or distant metastases were not allowed. However, patients were allowed to receive ADT, which was one of our stratification variables. Patients were excluded if they had a prostate volume on ultrasound or MRI of less than 15 cc or more than 90 cc, if they had bilateral hip implants or were claustrophobic so that they could not have MRI imaging, if they had inflammatory bowel disease requiring steroids, lupus, or scleroderma, if they had an active bleeding disorder, or if their lab values were abnormal. Here's the schema of the study. We basically took patients with low or intermediate risk prostate cancer, and we enrolled them on the study. First, we had a training cohort where each site enrolled 1 to 3 patients, and for each of these patients, fiducial markers and Barrigel was inserted with the use of a proctor. Once the investigators were credentialed, then subsequent patients were enrolled on the randomized arm, in which they were randomized 2 to 1 to Barrigel or control. For the patients on the Barrigel arm, they received hypofractionated radiation therapy and fiducials plus the spacer, whereas patients on the control arm just received hypofractionated radiation therapy and fiducial markers alone. Patients are currently being followed up for 3 years, and they're stratified by the utilization of androgen deprivation therapy or the intended utilization, as well as erectile quality based on the EPIC 26 score. The radiation regimen was 60 gray in 20 fractions. We enrolled 201 patients, including 136 patients who received Barrigel and 65 patients who did not. Here are the dose constraints for the trial. Generally, we had pretty clinically standard target constraints, rectal volume constraints, as well as bladder volume constraints, which reflected our current clinical practice in radiation oncology at our institution. Another unique aspect of our study is that we had a prospective core lab which reviewed each of our plans before and after insertion of the Barrigel and ensured that the plans were aggressively tried to minimize those to the rectum. And so on the image on the left, this was an initially submitted plan where the isodose line in yellow, the 50% isodose line, actually went beyond the posterior aspect of the rectal wall. And then in the updated plan that was done after initiation from the core lab, you can see that the 50% isodose line was located in the mid portion of the rectum. And so that had more improved dose symmetry. And this was done for about 25% of the patients on the control arm had to reevaluate their plans to make sure that optimal dosimetry was utilized. The key objectives of the study, there was a primary efficacy endpoint. Our primary endpoint was to determine the percentage of patients who achieved at least a 25% reduction in the volume of the rectum, receiving 90% of the prescription dose. This was for patients on the Barrigel only and with the same endpoint used in the SPACE OER hydrogel trial. We also had a key secondary safety endpoint, which was done to test whether Barrigel did not increase the incidence of acute grade 2 or higher GI toxicity within the first 3 months, and this was done in comparison with a control arm. This was designed as a non-inferiority study. So regarding the primary endpoint, about 98.5% of patients had at least a 25% reduction in the rectal V54. This exceeded the value of 25% with a p less than 0.001. The average reduction in rectal V54 was 85%, and 20% of patients had reached a near 100% reduction in the rectal V54 grade. Barrigel significantly improved all protocol-related DVH metrics, spanning from the V57 all the way down to the V38. The mean prostate rectum separation was about 12.9 millimeters immediately post-injection, and it was maintained at 12.6 millimeters at 3 months post-injection, despite a decline in the volume of the injected Barrigel that was noted on the scan between baseline and 3 months. And what this shows is that the spacing is maintained throughout the entire course of the hypofractionated radiation therapy. On the panel on the right, you can see plans of patients who were treated without Barrigel and then with Barrigel, and you can see that the 50% isodose line in yellow went through the rectum for the patient without Barrigel, but through the spacer for the patient who had received Barrigel. Furthermore, Barrigel was shown to be not only non-inferior, but superior in terms of the incidence of acute grade 2 or higher GI toxicity compared with a control. So on the study, 2.9% of patients had grade 2 or higher toxicity, compared with a 13.8% that was noted for patients on the control arm. In addition, there were zero Barrigel-related adverse events that was noted on the study. Here's a table of the acute toxicities in terms of both GI and GU toxicities at 3 months, which was evaluated for the key secondary endpoint, as well as at 6 months. And as can be shown here, the number and the percentage of patients who had acute grade 2 or higher GI toxicity was less for the patients on the spacer compared with the control arm. We also assessed whether there were any differences in the percentage of patients who had a minimally clinically important decline in bowel quality of life at 3 or 6 months, and we were not able to detect a difference at 3 months with a p-value of 0.13. So in conclusion, we found that Barrigel significantly reduced rectal dose. Barrigel reduced acute grade 2 or higher GI toxicity for patients who received hypofractionated radiation therapy. Furthermore, we are currently following patients long-term to see if there may be an improvement in quality of life at 3-year follow-up. Thank you.